Welcome everyone. Today I'll be discussing the management of antithrombotic therapy in patients with atrial fibrillation, particularly those undergoing percutaneous coronary intervention or PCI. This scenario presents a unique clinical challenge, which is preventing both stroke and stent thrombosis while minimizing bleeding risk. In patients with atrial fibrillation, stroke prevention is typically achieved with anticoagulation, specifically apixaban, rivaroxaban, dabigatran, or edoxaban. However, when these patients also undergo PCI, there is an added need for antiplatelet therapy to prevent coronary events. There is a dual risk of thromboembolism and bleeding, which makes antithrombotic management particularly complex, and careful selection of therapy is required to balance ischemic and bleeding risks. An important initial step is to first distinguish between valvular and non-valvular atrial fibrillation. Non-valvular atrial fibrillation refers to AFib in the absence of mechanical heart valves or moderate to severe mitral stenosis. This is the most common form and is best treated with direct oral anticoagulants, or DOACs, which are superior to warfarin in terms of stroke risk, mortality, and bleeding. This is in contrast to patients with mechanical valves or significant mitral stenosis. These patients are considered to have valvular AFib and must be treated with warfarin, as DOACs are not recommended in these cases. When AFib patients undergo PCI, the main decision is whether to use dual therapy consisting of an oral anticoagulant and a P2Y12 inhibitor, or triple therapy, which also includes aspirin. Studies have shown that dual therapy significantly reduces bleeding without increasing ischemic events, making it the preferred approach in most cases. The Annals of Internal Medicine and European Heart Journal have both supported this strategy. The current guideline support regimen involves using a DOAC in combination with clopidogrel for 6 to 12 months following PCI. Rivaroxaban, dabigatran, apixaban, and edoxaban have all been studied in this context. Rivaroxaban is typically dosed at 50 milligrams daily, while dabigatran is used at 150 milligrams twice daily. Apixaban and edoxaban have also been validated in major trials like Augustus and Entrust. In select patients, warfarin combined with clopidogrel or ticagrelor is also an option, as supported by the WOEST study. Ticagrelor may be used in hospital or in those with very high thrombotic risk. I should also mention the recommended dose of clopidogrel in a patient with AFib who is being treated with a DOAC plus clopidogrel. As per these trials, the recommended clopidogrel dose is 75 milligrams once daily. Now, triple therapy, which is adding aspirin to a P2Y12 inhibitor and an oral anticoagulant, may be considered briefly in patients with very high thrombotic risk. However, aspirin is usually stopped after 1 to 6 weeks due to its contribution to bleeding. After 12 months, most patients can be safely transitioned to oral anticoagulant monotherapy, as demonstrated in the AFIRE trial. The overarching principle is to tailor therapy to the patient's thrombotic and bleeding risk, and to de-escalate intensity when it is safe to do so. Now, let's talk about the AFIRE trial in more detail. The AFIRE trial investigated patients with non-valvular atrial fibrillation and stable coronary artery disease who were either more than 12 months post-PCI or had angiographic confirmation of stable disease. The study demonstrated that rivaroxaban monotherapy was non-inferior to combination therapy with a DOAC and antiplatelet agent in preventing cardiovascular events and death, and it was superior in reducing major bleeding. As a result, this trial supports discontinuing antiplatelet therapy after 12 months, provided the patient does not have other indications such as a recent acute coronary syndrome or a new stent. The trial used a dose of rivaroxaban 50 milligrams daily, adjusted for renal function following Japanese guidelines. This strategy has since been incorporated into major guidelines, including those from the ACC, AHA, and HRS, which now recommend DOAC monotherapy for long-term management in this patient population. So to wrap things up, this summary table is going to capture the key takeaways from our discussion In patients with non-valvular atrial fibrillation, DOACs are the preferred anticoagulants due to their better safety and efficacy profiles compared to warfarin. For valvular atrial fibrillation, which specifically includes those with mechanical heart valves or moderate to severe mitral stenosis, warfarin is going to remain the standard of care. When AFib is combined with PCI, dual therapy, usually a DOAC plus clopidogrel, is preferred. This approach has been shown to significantly reduce bleeding without compromising protection against ischemic events. Triple therapy, which adds aspirin to the regimen, should be reserved for patients at high thrombotic risk and used only for a short duration, typically 1 to 6 weeks. After the first year post-PCI, most patients can transition safely to oral anticoagulant monotherapy as supported by the AFIRAL trial. Ticagrelor may be used in hospital or in very high-risk patients, but is generally avoided long-term due to increased bleeding. Lastly, several DOAC options are available, including rivaroxaban, dabigatran, apixaban, and edoxaban, each validated in major clinical trials with specific dosing strategies. I hope this video was helpful. Thank you for watching.